Bismillahirrahmanirrahim. In the name of Allah, who is the most beneficent and the most merciful. The thought of the day is failure will never overtake me if my determination is to succeed is strong enough. Assalamu alaikum. My name is Dr. Inshrah. I am a PGR of Community Medicine and Public Health at King Edward Medical University, Lahore. Today, I'm going to critically appraise an article. Its title is Trend Analysis of Disability Adjusted Life Years Due to Cardiovascular Diseases, Results from the Global Burden of Disease Study 2019. And I'll be appraising it under kind supervision of Professor Dr. Saira Afzal. For this article, we will be using Gather checklist. So now we will move to the article. Trend analysis of disability adjusted life years due to cardiovascular diseases, results from the Global Burden of Disease Study 2019. Abstract. Background. Cardiovascular diseases, CVDs, are the #1 cause of global mortality, representing about 1/3 of all deaths across the world. The objective of the present study was to model the global trend in disability adjusted life years, DALY, and its components due to CVD over the past few decades. We also aim to evaluate the longitudinal relationship between CVD, DALY, and Human Development Index, HDI, in this period of time. Methods. The 8 standardized rates of years lost due to disability, YLD, years of life lost, YLL, and DALY were extracted for cardiovascular diseases from the Global Burden of Disease Study GBD 2019 in year 1990 to 2019. Additionally, the United Nations Development Programme UNDP database was used to retrieve HDI values for all world countries at the same time period. The trend analysis was performed using joint point regression model. The obtained results revealed a significant downward trend for Delhi and its components, with the average annual percentage change of -1.0, -0.3, -1.1 per 100,000 population, respectively, for Delhi, YLD, and YLL. We also found that countries with high or very high levels of HDI have remarkably experienced steeper declining slopes of trend than those in the lower levels of HDI over the study period. Conclusions. Although the observed decreasing trend of CVD burden is a hopeful message for all world countries, the considerable gap in slope of trend between richer and poorer parts of the world is a serious alarm for health policymakers. Regarding this, there is an urgent need to put more efforts on implementing preventive programs, improving the level of patient care, and providing efficient treatment, especially in the region with lower levels of HDI. Introduction. Cardiovascular diseases, CVDs, are the leading cause of mortality and one of the most important causes of disability in the entire world. In the last 3 decades, the global prevalence of CVDs had an increase of 93% from 271 million in 1990 to 523 million in 2019, and the CVD mortality has risen about 54% from 12.1 million in 1990 to 18.6 million in 2019, which represents about 1/3 of the annual death across the world. Regarding 25x25 global action plan suggested by the World Health Organization WHO in 2013, which targets to reduce premature deaths from non-communicable diseases by 25% by 2025. Although high-income countries could meet these targets for 2025, limited access to healthcare and treatment, insufficient health funding, poor government, and more focus on curative services rather than preventive action make these goals hard to achieve in low and middle-income countries. Reviewing the revealed works in this field shows that there are few published articles about the long-term trends of CVD burden and its association with socio-economic status of the world countries. Almost all of them have used descriptive approaches to illustrate the trend of CVD burden and its relationship with social or economic indices. Regarding this, we decided to conduct the current study to explore the global trends of years lost due to disability, years of life lost, and Delhi in a long period from 1990 to 2019, and investigate the longitudinal relationship between CVD burden indices and Human Development Index as the key indicator for evaluating the socio-economic status of the world countries. Methods. GBD dataset. In this study, we extracted the 8 standardized CVD, YLD, YLL, and Delhi rates per 100,000 people from the GBD study 2019. HDI dataset. In this study, we extracted the HDI data for 185 countries between 1990 and 2019 from the UNDP website. To simplify the statistical analysis, we combined the results with HDI levels of low and medium in a category and levels of high and very high in another category. Statistical analysis. To describe the trend of cardiovascular diseases, YLD, YLN, and Delhi rates, the mean and its 95% confidence intervals were reported globally by gender and HDI level. In addition, to identify the pattern of changes in these three indices, joint point regression analysis was used. This is the formula for joint point regression analysis. Here is given details about different factors that have been used in this formula. By fitting the joint point regression, we can calculate the annual percentage change APCs in rates between the estimated change points. To find APC, this is the formula. For each fitted joint point regression model, the average annual percentage change AAPC can be estimated. The 95% confidence interval for APCs and AAPCs were also computed to evaluate the statistical significance of the estimates. The joint point regression analysis was performed using the joint point software 4.8.0.1. Results. In this study, the burden of cardiovascular diseases for 194 world countries was extracted from 1990 to 2019. Regarding the estimates for YLL rates, the estimated APCs shows annual percentage change of minus 0.1, minus 1.2, minus 1.6, and minus 0.8 in YLL rates. So respectively in the time intervals of 1990 to 94, 94 to 2005, 2005 to 2013, and 2013 to 2019. The fitted joint point regression model to Delhi rates shows a similar behavior with the results of the fitted model to YLL data from the results of the fitted model to YLD rates. The estimated APC indicates significant annual percentage change of minus 0.3, minus 0.2, minus 0.4, minus 0.3, and minus 0.1 in YLD rates respectively in the time intervals of 1990 to 94, 94 to 2000, 2000 to 2009, 2009 to 2016, and 2016 to 2019. Moreover, the estimated AAPCs from these models imply a mean annual fall of 1.1, 0.3, 1.0 per 100,000 respectively in the YLL, YLD, and Delhi rates for global population of the world over the study period. Table 4 shows the obtained estimates from fitting joint point regression analysis model to YLD, YLL, and Delhi rates certified by the HDI levels. YLD data for countries with low or medium HDI level had different trends. The estimated AAPC shows an annual percentage change of 0.3, minus 0.4, 0.8, minus 0.6, 0.6, minus 0.2, and 0.1 in YLD rates for these countries, respectively in the time intervals of 1990 to 95, 95 to 98, 98 to 2001, 2001 to 2004, 2004 to 8, and then 8 to 19. For countries with high or very high HDI levels, the estimated APCs are minus 1.6, minus 0.2, minus 0.7, and 0.1 respectively for the time intervals these. The estimated AAPCs for countries with higher HDI level had an average annual decrease of 0.4 per 100,000 in YLD rates between 1990 and 2019, while those in poorer areas have experienced no significant change in the same period of time. Comparing the obtained results from fitting the joint point regression model for YLL and Delhi rates is indicated in table 4. Both of these results have similar estimates. Therefore, we only target the estimates for Delhi rates. In low and medium HDI countries, estimated AAPCs are 0.7, minus 0.3, minus 1.0 respectively in 1990 to 1995, 95 to 2013, 2013 to 19. In high or very high HDI countries, the APCs estimates are minus 1.9, 1.6, minus 2.1, and 0.5 respectively in this period 1990 to 2000, 2000 to 2003, 3 to 13, and 13 to 19. Comparing the estimate AAPCs of minus 0.3 and minus 1.1 per 100,000 indicate that the average annual percentage reduction of Delhi rates in wealthier regions was about 3.7 times of this reduction in the poorer areas. Before we move to the discussion, let me show you these different tables and graphs. This is the table 1 that have descriptive statistics for CVD, Delhi, YLD, and YLL rate per 100,000 by gender from 1990 to 2019. For this same table, this is the graph. We can see that YLD, YLL, and Delhi, all of these three have decreasing trends. This is the result for joint point regression model. And here also we can see that these are the different APC values for different time intervals for YLD, YLL, and Delhi. In the same way, these graphs are shown, and then this table, this graph, again this table and this graph follows the same trend, but here we have used HDI levels rather than the gender. Now we'll move to the discussion portion. Okay, so here. In the presented epidemiological study, we investigated the global trend for CVD, YLL, YND, and Delhi in the last 3 decades. According to our findings, there is a worldwide downward trend in all 3 indices in this period of time. However, this reduction has occurred much faster in countries with higher HDI levels compared to those with low or medium HDI levels. In a study by Ruth et al., they reported a worldwide decreasing trend of YLD from 1990 to 2019. In another study, the researchers used a systematic analysis for global burden of disease 2019 and confirmed the global downward trend of YLD over the last 3 decades. Similar results were obtained in the study of Martinez et al., a study in Eastern Mediterranean countries. Now, regarding our findings about CVD YLL trend, it is apparent that nearly all world countries have experienced a significant declining trend over the past 3 decades, with an annual mean reduction of more than 2,000 per 100,000 individuals. In the Eastern Mediterranean regions, about 15% decrease in CVD Delhi was reported in the period 1990 to 2015. Among the countries in this region, Afghanistan had the highest YLL values, and Pakistan was the only country with an upward YLL trend in this period of time. For CVD Delhi, we know that there was a decreasing trend in this study, and similar results were obtained in the study of Ruth et al. As a key objective of present study, we assess the relationship between HDI level and CVD burden indices. And there was a negative association between HDI level and CVD burden indices. Areas with higher HDI have experienced remarkably steeper slope of downward trend than poorer regions over the study period. In a cross-sectional study based on the age standardized mortality rates ASMR of non-communicable diseases reported by the WHO in 2015, the researchers obtained an inverse correlation between HDI and ASMR. Similar results were obtained by Ruth et al. And Amini et al. In 2020, the GBD 2019 used the SDI as the measure of development and concluded that countries and territories with lower SDI levels have experienced steeper rate of change in age standardized Delhi rates for all causes except HIV, AIDS, natural disaster, and war and conflict over the last decade than those with the higher values of SDI. More detailed comparison between the findings in the present research and the reported results in the above mentioned and manuscripts reveals some differences. In general, a point-by-point comparison between our findings and the results reported that in described manuscript seems quite difficult because of discrepancies in the statistical analysis procedure stratification based on age groups and sex, methods of reporting the findings through relevant figures and tables, and utilized time intervals for calculating different indices. Utilizing the reported data from the Global Burden of Disease 2019 study as one of the most comprehensive and reliable data source in this field is another strength point of this present study. At the same time, there are numerous indicators which are statistically related with the burden of CVD in different populations: ethnicity, smoking, alcohol consumption, obesity, high blood pressure and cholesterol, diabetes, dietary habits, inactivity, family history, indoor-outdoor air pollution, occupational exposure, and socioeconomic status are some of the individual and societal level risk indicators of CVD. Ignoring the concurrence effect of the described indicators on burden of CVD was the foremost limitation of our study. Conclusion: in general, our findings revealed that CVD Delhi and its components had a decreasing trend in the past 3 decades globally. Comparing the slope of downward trend between countries with low or medium and high or very high HDI level raises some concerns. It seems more developed countries have apparently experienced steeper declining slope of trend than poorer regions of the world. To reach the ambitious goals of the WHO 25x25 Global Action Plan, there is an urgent need to develop relevant strategies for promoting the level of knowledge about this disease and its related factors, implementing efficient screening and preventive plans, and facilitating the accessibility to proper care and treatment, especially regions with low levels of HDI. Funding source: no financial support was received for this research. And then availability of data and materials. We confirm that all methods were performed in accordance with the relevant guidelines and regulations. The data set analyzed during the current study are available in GBD database and then UNDP database. Now we'll move to the checklist. We'll see which points are followed and which are not. Title and abstract. Identification as the global burden of disease in the title. Yes, it does mention in the title that it is the global burden of disease study. Structured abstract with background, objectives, design, results, and conclusion. Yes, it is a structured abstract as proper headings are given in the abstract. Define the indicators, population, including age, sex, and geographic entities, and time periods for which estimates were made. Yes, it does define the indicators YLL, YLD, and Delhi, population across 194 countries by gender and HDI levels, and time period 1990 to 2019 in the methods and results portion. List the funding source of the work. Yes, it mentions at the end of the article that there was no funding source. For all data inputs from multiple sources that are synthesized as part of the study, describe how the data were identified and how the data were accessed. The identification process could have been elaborated further, but the article states in the methods section that data were extracted from the Global Burden of Disease Study 2019. Also, it is written at the end of the article that data were extracted from the GBD database. Specify the inclusion and exclusion criteria. Identify all ad hoc exclusions. No specific inclusion and exclusion criteria mentioned. No ad hoc exclusions identified. But because we know that this study was on the CVD burden of disease, so only such studies were taken that were on the patients of cardiovascular diseases. Provide information on all included data source and main characteristics for each data, report, reference, information or contact name or institution, population represented, data collection method, years of data collection, sex and age range, diagnostic criteria or measurement method, and sample size as relevant. The article mentions in the methods portion that it has used GBD study data, that is a comprehensive data set covering over 200 countries and territories with data categorized by age and sex groups. Otherwise, no additional information regarding any of the above mentioned kind is given. Identify and describe any categories of input data that are potentially important biases. Example given based on characteristics listed in item 5. The author discussed potential biases in that data in the discussion section of the article, such as those arising from the varying data quality across regions and the impact of socioeconomic factors on health outcomes. For data input that contribute to the analysis but were not synthesized as part of the study, describe and give sources of any other data input. Yes, the study describes the use of HDI data accessed from the UNDP database to analyze CVD burden trends by socioeconomic status, and it was mentioned in the methods portion. For all data input, provide all data inputs in a file format from which data can be efficiently extracted. Example given is spreadsheet rather than a PDF, including all relevant metadata listed in item 5. For any data input that cannot be shared because of ethical or legal reasons such as third-party ownership, provide a contact name or the name of the institution that retains the right to the data. No specific extractable format provided in the article. However, it directs readers to the GBD and UNDP database to access the raw data at the end. Provide a conceptual overview of the data analysis method. A diagram may be helpful. The article mentions using joint point regression in the statistical analysis section of the method. No diagram was given. Provide a detailed description of all steps of the analysis, including mathematical formula. This description covers as relevant data cleaning, data pre-processing, data adjustments, and weighting of data source and the mathematical or statistical model or models. It does provide a brief account of the joint point regression model. It also provides the formula for calculating APCs and AAPCs in the statistical analysis portion. No more information was given. Describe how candidate models were evaluated and how the final model was selected. It doesn't explicitly detail how different candidate models were evaluated or chosen, and only mentions the use of joint point model. Provide the results of an evaluation of model performance, if done, as well as the results of any relevant sensitivity analysis. Model performance is demonstrated through descriptive statistics of APCs and AAPCs values across time intervals in the results section. However, a specific sensitivity analysis is not detailed. Describe methods for calculating uncertainty of the estimates, state which sources were and were not accounted for in the uncertainty analysis. The article details the calculation of uncertainty using confidence intervals around APCs and AAPCs values in the statistical analysis portion. It doesn't, however, outline additional sources of uncertainty calculation. Results and discussion portion. State how analytic or statistical source code used to generate estimates can be accessed, not explicitly mentioned in the article. Provide published estimates in the file format from which data can be efficiently extracted. While the study provides tables and figures with results, it does not offer data in a directly extractable format, example given in spreadsheet. Report a quantitative measure of the uncertainty of the estimates, example given uncertainty intervals. The study reports uncertainty through confidence intervals for APCs and AAPCs values in the result section. Interpret results in the light of existing evidence if updating a previous set of estimates provides reasonable changes in estimates. The author do compare their findings with prior research on CVD burden, highlighting trends consistent with previous studies and addressing differences in the discussion portion. Discuss limitation of the estimates, include a discussion of any modeling assumption or data limitations that affect interpretation of the estimates. This study addresses limitations, noting that variations in the data quality across regions and potential biases in socio-economic data might impact findings. This is mentioned in the second last paragraph of the discussion. This is the link to our YouTube channel. Thank you for your attention.
Thank you very much.